Is Dr. Sneha Batra here? Yeah, so she'll be presenting a case of on central retinal vein occlusion in a 15-year-old boy as a presenting symptom of protein S deficiency.
As a side comment to that one, nowadays the availability of OCT angio definitely has made it very easy to diagnose an associated celoretinal artery occlusion with CRVO. Earlier it was more dependent on visual acuity or some doubts, but now with the OCT angio you can confirm it easily. And the advantage is you can give a poorer prognosis. Even if the CME goes away with your injections, the visual prognosis is worse. Yes, doctor.
Good morning, everyone. I will be presenting a case on central retinal vein occlusion. We had a case of an 80-year-old just before this, and now in a 15-year-old boy as presenting symptom of protein S deficiency. So CRVO in the young is now becoming more and more common, and it constitutes around 10 to 15% of all CRVO cases. In these cases, hereditary thrombophilias constitute a major risk factor, and we do screening tests for them. But protein S deficiency is a very rare condition. However, it is an important condition, as we saw in this case. So this 15-year-old boy presented to us with a history of sudden painless dimness of vision in his left eye for the last 1 week. He was diagnosed elsewhere as optic neuritis, and he had already been started on oral prednisolone tablet. He was taking around 60 milligrams per day at that time. So the right eye, the vision was absolutely fine. Left eye had 6/18 N10. IOP was normal, anterior segment was normal. Coming to the fundus examination, again the right eye was fine. The left eye showed disc edema, numerous flame-shaped hemorrhages in all the 4 quadrants with vascular tortuosity. So we concluded that this was a case of central retinal venous occlusion. We did an FFA also because he had been diagnosed with a different entity elsewhere, and we saw a very typical picture of CRVO with disc leakage, with vascular tortuosity, some amount of blocked fluorescence. Not a lot of CNP areas were seen. And on OCT, we could see that there was macular edema with subretinal fluid. The maximum thickness of the maximum retinal thickness was 567 microns at this time. The blood pressure was normal, cardiovascular examination was normal, all other systemic examination was normal. There was no significant family history or past history in this patient pertaining to coagulation disorders. So we made a provisional diagnosis of CRVO of the non-ischemic type. We had a differential of papillophlebitis, but because of the younger age, male gender, decreased vision and presence of significant macular edema, we thought CRVO was the more likely diagnosis. So we advised an injection of intravitreal ranibizumab. We asked to taper off these steroids, and we gave some blood tests to rule out what coagulation abnormalities could be present. Now, interestingly, the patient's mother said that I do not want to give an injection to my son, and they did not come back on the day of the injection. They came back after 1 week, and she said, my child is feeling much better. The vision had improved 1 line to 6/12 N8. And they came back with the blood tests also, which showed protein S deficiency. We referred to a hematologist who started him on warfarin. All the other blood tests were normal. The homocysteine level, protein C, antithrombin, everything was fine. So we did not give the injection because the patient was feeling better. We followed him up, and after 10 days, the vision had improved. So this is the first picture when they had come back after 1 week. 299 microns of CST, some amount of subretinal fluid present, and after 2 weeks, the subretinal fluid, macular edema, all had gone, and the vision had come back to 6/6 N6. So CRVO in the young is less than 50 years old. Of course, hypertension, diabetes, and hyperlipidemia are important. Additionally, these thrombophilic risk factors need to be investigated, hyperhomocystinemia being the most common one, but some of these uncommon diseases also have to be probed. The family history is very, very important. What is protein S? It works as a cofactor of protein C to prevent the activation of factor X and thrombin in normal physiological conditions, hence preventing thrombosis. So most of these children, if it is a homozygous deficiency, it presents right in the infancy, and if it's heterozygous, it presents later, and lifelong anticoagulation treatment may be required in these cases. So it is a very rare case, and in India we could find only one prior case of CRVO with protein S deficiency. We saw another study of 50 young patients with CRVO. None of them had protein S deficiency. So it is uncommon. The literature suggests that intravitreal ranibizumab is the first line of treatment. However, CRVO in the young may have a predominant inflammatory component. Some people have tried out dexamethasone implant also. But the treatment in this case was not in our hands. The steroid had already been started due to a misdiagnosis, and we saw that there was a rapid and uneventful recovery. So can it be a treatment? We are not very sure. We would probably still suggest ranibizumab as the first line of treatment, but it is something that I wanted the house to discuss as well. These are my references. Thank you.
Good case.
Very interesting case.
Thank you.
You're right that CRVO in the young, many times we see significant recovery without treatment. And earlier, about 15 years back, we used to give oral steroids as the treatment for young CRVOs, and the diagnosis was papillophlebitis,
Right.
or the Lyell-Weber syndrome, where it is believed to be an idiopathic inflammatory disorder. So with that understanding, the conventional treatment was oral steroids only.
Okay.
Then we stopped giving oral steroids, at least because for various reasons. But we still do not need to immediately treat them. Many of them recover spontaneously. Oral steroids can be given. And then if you end up giving an intravitreal, most of the time they don't need more than one injection. They hardly have recurrences. But now I'm talking of idiopathic ones. I'm not talking of somebody who has a known etiology where we might expect recurrences also. So I'm not speaking about your case, but this is in general for most young patients.
Okay.
And of course, in a young patient, very thorough workup. You picked up a very rare disease which we don't even investigate for mostly.
Yes.
But we generally should investigate for all kinds of inflammatory diseases like sarcoid, SLE, vaginous, even leukemia, lymphoma, and other homocystinemia, in addition to diabetes, hypertension, dyslipidemia.
Yes.
So it has to be a very thorough workup before we say it is idiopathic. Most of the cases in the young are idiopathic inflammatory. Most of the cases, you will not find the etiology. When in COVID times we were getting cases post-COVID infection or post-vaccine with CRVO. And again, most of them were resolving with oral steroid and anticoagulants, warfarin or whatever. Only a very few of them required an injection.
Okay.
This
Yes, ma'am.
protein S deficiency, this is due to the mutation.
Yes, ma'am.
So this is going to be recurrent.
Yes.
They say we will have to stop it and do the counseling
Yes, ma'am.
and do the genetic analysis in
Yes.
this patient.
Yes. So we had, yes, ma'am.
Anti-coagulant, I think the diluted heparin is better than the
Okay.
And since they are now on anticoagulation, we may not expect to see recurrent
Yes.
events.
Recurrences again. So we had referred to a hematologist. He had suggested the warfarin to be continued